Welcome to today's session, the EAJNS Journal Bootcamp. My name is Najma Adan, and I'll be your moderator for this session, representing XYZZ Research Department. The EAJNS Journal Club is a collaborative initiative by the East African Journal of Neurological Sciences, together with JOGECA, JOGECA, and the Annals of African Surgery and the Anatomy Journal of Africa, in partnership with XYZZ Met, SCORE, UN Research Club, CUMREC, and the Student Surgical Forum. Our goal through this bootcamp is to promote scientific critical appraisal skills, enhance leadership of local journals, and spark greater interest in publishing and peer review among early career researchers and medical students. Today's session will run for around 1 hour, structured as follows. The first 15 to 20 minutes presentation by one of our partnering organizations, summarizing the selected paper, and a 20-minute open discussion and appraisal by the audience, and finally, closing remarks and insights from our guest speaker, Dr. Mary Kirie Koike. Please feel free to share your thoughts, questions, and critiques in a respectful and engaging manner. This is a safe learning space for all levels of experience. With that, it's my pleasure to invite Wangari Njuguna to take from CUMREC to take us through today's paper titled "Risk Factors for Invasive Cervical Cancer Among Women Living with HIV and AIDS" at Jaramogi Oginga Odinga Teaching, Research and Referral Hospital in Kisumu County, a 5-year hospital-based case control study.
So, my name is Lucy Wangari Njuguna. I am the Partnerships and Liaisons Officer for CUMREC. CUMREC stands for Kenyatta University Medical Research Club, and we are based in Kenyatta University, as is in the name. We are basically a group of students who are part of a club. We encompass medical students, pharmacy students, public health, biomedical sciences, everything you can think of, even nutrition. We have nursing. And so we partnered with East African Journal of Neurological Sciences to bring you these sessions for critical appraisal. And we hope that you will learn a lot from them. I'm personally learning a lot. So I hope you enjoy. So today's session, I will begin. This is the 4th session. I will begin with a slight icebreaker. So, what did the medieval gynecologist say to his patients? At your cervix, milady. Yeah, it's just a slight icebreaker. So we begin the actual session. So, our paper this time around was a case control study. And I thought it was important for us to actually go through what a case control study is and understand it, then we can get down to business. So, what is a case control study? So, a case control study is a type of observational study commonly used to look at factors associated with diseases or outcomes. So, I will give you an example of Kaposi sarcoma. So, when we think of Kaposi sarcoma, one would want to know, who does Kaposi sarcoma affect? So, we would go out to a population, we pick a sample size or a sample population, and we decide we're going to pick a certain number of patients based on a certain formula and decide, or see rather, if at all there is anything that makes a specific group of people get Kaposi sarcoma and another specific group of people not to get this Kaposi sarcoma. So what we do, we pick our exposure. So the exposure is maybe a disease or an environment or a situation, and the outcome in this case would be Kaposi sarcoma. So when we study this population, we find that there's a certain group of people that get the Kaposi sarcoma, but there's a certain group of people that doesn't. So now we're going to have our cases, which in this case is the people who actually have the Kaposi sarcoma, and we have the controls, which is people who don't have the Kaposi sarcoma. And then we look at the element in this case, which these people who are exposed to Kaposi sarcoma have, yeah? So we find out that the people with Kaposi sarcoma actually have HIV, but the people who don't get Kaposi sarcoma don't have HIV. So I've mentioned 4 things here. I've mentioned an exposure, I've mentioned an outcome, and I've mentioned variables. So, and I've also mentioned cases and controls. So that's what basically entails case control study. We have cases and controls, and we have outcomes, and we have exposures. So when you look at case control studies, what do you think the advantages are? Okay, they're clearly on the screen. So the advantages include that they allow us to study rare diseases, yeah? And also it is possible to study multiple risk factors at once. And other than the rare disease bit, we're going to see in our today's paper how we can actually study multiple risk factors at once as opposed to studying one risk factor at a time. So what is the disadvantage? The disadvantage is that this type of study has a potential for recall bias. What is recall bias, one might ask? So recall bias simply means that there is an increased likelihood that those with the outcome will recall and report exposures compared to those without the outcome. And I'll give another example here to bring it into context. So you have a group of patients who presented to hospital, or rather you are in a community, maybe you're the only doctor in a certain area, and people are coming to hospital and they have tons of diarrhea, and you don't understand why they have tons of diarrhea, but of course you're going to diagnose and see what the issue is. Then when you go out into the community and then you start studying this community, you realize that there are people who show up to the hospital with the diarrhea, yes, but the people who live within the same community that don't have this diarrhea. So when you study them, they'll tell you the reasons why they have the diarrhea, maybe something they ate, something they took, or something like that. And then when you're studying the population that actually has the diarrhea, they start telling you, unajua, by the way, I passed through a certain kibandaski and I ate something specific. And yes, that's what made me sick. But the people who don't have this diarrhea, and probably they'll not even mention that they visited the same kibandaski and they probably did not even get that same diarrhea, because for them, it was inconsequential. Like they did not feel like it was important for them to mention the fact that they experienced this. So yeah, that's how I would understand recall bias. So case control studies can be used to establish a correlation between exposures and outcomes, but they cannot be able to establish causation. So they can show you that there's a relationship between this factor and this certain disease, but it cannot show you what caused this disease, yeah? So the main method for case control studies of analysis rather are odds ratios. So simply put here, the odds ratio is, sorry, I can't see. So odds ratio is the odds of having a disease or outcome with the exposure versus the odds of having the disease without the exposure. Yeah, that's simply what odds ratio means. So we will start the presentation now looking into the study itself. Okay, so we'll start with the title of the paper. So I highlighted so that we can analyze. You can follow me as I analyze. So for the title, it reads Risk Factors for Invasive Cervical Cancer Among Women Living with HIV and AIDS at Jaramogi Oginga Odinga Teaching and Referral Hospital in Kisumu County, a 5-year hospital-based case control study. So what can we derive from this title? So we can see, first of all, we have the exposure, which is HIV and AIDS. We have the outcome, which is invasive cervical cancer in this case. We have the study type. We were told that it is a 5-year hospital-based case control study. We have the population, which is women living with HIV and AIDS. And we have the setting, which is Jaramogi Oginga Odinga Teaching and Referral Hospital in Kisumu County. Let's move on to the authorship. So in the authorship, you can see the author has listed the authors. So we have Achapa RK, we have Kosgei RJ, we have Soti A. We have all these people who are said to participate in writing and going through this paper. And we also have the affiliations. The first affiliation is Departments of Obstetrics and Gynecology from the University of Nairobi, Kenya. Then we have the second affiliation, which in this case is the Department of Obstetrics and Gynecology from the Kenyatta National Hospital, Kenya. And we even have a correspondence address in this case, which is probably the first author, kavatarail@gmail.com. Yeah, and you can see that the author also listed the people with their affiliations up here. You can see there's a 1 and there's a 2 here. Yeah. So from the abstract, how can I summarize this abstract? So from the abstract, you can see that cervical cancer is the leading cause of mortality among women of reproductive age in resource-constrained countries, which are also known as low and middle-income countries. So Kenya is an example of a country where we are resource-constrained, and we're actually going to see why we are concluding this in our paper. Secondly, HIV accelerates the transition from cervical dysplasia to invasive cervical cancer. So you can see that cervical dysplasia is a precancerous lesion in this case. And when somebody acquires HIV and when they're immunocompromised, you find that they end up getting invasive cervical cancer in the end. According to the author from their abstract as well, background specifically, you can also see that this paper specifically is an overview of the risk factors, and these risk factors are significant in determining that whether these women are going to get invasive cervical cancer from the fact that they have HIV. And also from the background, we can tell that there's scarce data on the issue, and we'll actually see later why in the discussion. So, what is the objective of the study? Clearly stated, to determine the risk factors of invasive cervical cancer in HIV-infected women in Kisumu County. And what is the methodology of our study? So our study was a case control study, like we earlier stated. So it is an unmatched 5-year case control study, and they also stated the time period in this case, which is from 2012 to 2016. So you can see that is 5 years. What is our setting? Jaramogi Oginga Odinga Teaching and Referral Hospital. And what is our population? So our population was HIV-infected women, both with and without cervical cancer, invasive cervical cancer rather. And you see, these women were specifically handpicked either from the comprehensive care clinic or the gynecology clinic at Jaramogi Oginga Odinga Teaching and Referral Hospital. So, data collection and analysis. What method did this pool use? Or what method did the author and the co-authors use? So they used structured questionnaires to extract the data from patient records, as we will later see. And then they also did a univariate and multivariate analysis. And from the abstract still, they are telling us that their p-value is less than 0.05, which I would assume in this case means that the data is significant. It's statistically significant. So, what were the results of this study? We find that the results of this study stated that, first of all, the women who were likely to have invasive cervical cancer were one, of a background that was of a poor socioeconomic status. They had a lower educational level compared to those women without cervical cancer. They had a higher parity than the women who had no cervical cancer and were HIV infected. They lived far from hospital, and they had a lower CD4 count. Yeah, those are the results. And in conclusion, according to the author, we see that she further stated the factors that she felt were most significant compared to the women without invasive cervical cancer, which in this case are poor economic status, the fact that they lived far away from the hospital, and the fact that they had done more prior pap smears and they had lower CD4 counts. And we're just going to keep on seeing why she found these things significant as she was doing her research. So, what were the keywords for this study? So the keywords, according to the author, were human immunodeficiency virus and invasive cervical cancer. As for the introduction, so the author states that cervical cancer is a surmountable global burden and highly preventable. And we know this because we see that there are countries like Australia which have actually eradicated HPV and cervical cancer, and they do this through vaccination. So we know about vaccinations like the Gardasil 9, which are administered to mostly teens, both girls and boys, so that by the time of sexual debut, they're already guarded against human papillomavirus, and they cannot transmit it to other people, which will ultimately lead, if you understand the pathophysiology of cervical cancer, will ultimately lead to invasive cervical cancer. So according to the author, we can see that the global new estimated cases are at 570,000. That's a lot of people. And we can say that the global estimated deaths, which is slightly more than half, is 311,000. So let's see the status in our country. So in resource-constrained countries, 9 out of 10 deaths globally come from them. So that's at 87%. And we can see that in Kenya, the annual number of cases is recorded at 5,250 cases. And then the annual deaths are at 3,286. That's more than half. So we're losing more than half of our population that has been diagnosed with cervical cancer. Just because we are resource constrained, we have issues in management, and we all know the whole story concerning healthcare in Kenya. So when we now look at Kisumu County, where the study is being done, we can see that the prevalence of HIV and AIDS is at 19.9%, which is 3.4 times the national prevalence rate. So it is alarming. And you can see why it is very important to study cervical cancer in this population, because cervical cancer is actually an AIDS-defining malignancy. And you can imagine that if these people have they're reporting more cases of HIV, then they're definitely going to report more cases of cervical cancer. So you can see the situation in Kisumu County still, whereby 5.7% is the screening rate. So let's see what the author recommends from this study later on. We have the methodology, as earlier stated. This is really repetitive all over, but we're going to see why it's important. So the study design, as earlier stated, it is an unmatched 5-year case control study. The time frame is between 2012 and 2016, and the data sources, as earlier stated again, are patient records. And these patient records were used to derive the information that is whether there is presence or whether there's absence of invasive cervical cancer in women infected with HIV and AIDS in Kisumu County. So, what is the study setting? Again, the study setting is Jaramogi Oginga Odinga Teaching and Referral Hospital, and the study population is HIV-infected women with and without invasive cervical cancer attending either the comprehensive care clinic or the gynecological clinic at Jaramogi Oginga Odinga Teaching and Referral Hospital. So, what was the study procedure? So, as earlier stated again, the author made sure that she stated that controlled records were received at the same time as every case that received care for invasive cervical cancer. So I assume this is a way of getting rid of bias in any case, survival bias especially for this specific case. The sampling criteria. So there was a whole flow chart in the study, but I just created my own so that we can at least go through this together. So the beginning, the study recruited 4,200 patients. And then now they started excluding the patients. So they excluded those who are less than 18 years, those with absent histopathology, those with missing data, those that were referrals, and those that had cervical intraepithelial neoplasm, also to eliminate survival bias. So what was the including criteria? So the patients were older than 18 years. They had been screened between 2012 and 2016, and they attended the comprehensive care clinic or the gynecology clinic. So from including and excluding, what they finally end up with. So they finally recruited 1,615 patient records. And then they calculated the number of the sample size they needed. And they found that when they randomly select, they needed 100 patients for the cases and 100 patients for the controls. And so they randomly selected these cases and controls, and they end up with a sample size of 200, half of which were cases and half of which were controls. So they calculated the sample size using this formula. I know it looks big, and some of us last did math probably intensively in high school. But other than that, I think I can try break it down just for people who are still new to research. And I'm sure there's some OGs here who will probably laugh at me if I make a mistake, but bear with me. So what is N? N is the sample size needed for each group, yeah? And then we have Z alpha over 2, which in this case will be the critical value for the significance level. So in this case, we have this here. This is what we would use. Okay. Yeah. And then we have Z1 hyphen beta, which is the critical value for the power of the rest of the test, not the rest, sorry, the test. And then we have P1, which is the expected prevalence or proportion in the first group. And P2 is the expected prevalence or proportion in the second group. So when we do the math for the mathematicians and the statisticians, we get 100 cases and 100 controls for each. So we have our data variables. I had earlier stated that case control studies are very emphatic on variables. So in this case, what the exposure is and what the outcome is. And we're going to see a lot of those when we start now getting down to the data. So we have the main exposure variable in this case, which was the history of pap smear screening. And we have other exposure variables, which are socio-demographic factors, sexual and reproductive behavior, and HIV-related factors. And then we have the outcome variable, which in this case is invasive cervical cancer. So let's move on to the next slide. So how did the author and the co-authors manage the data? Like we had said before, they used structured questionnaires for data extraction. And then they would enter the data obtained into a Microsoft Access database, either the author themselves or people who were trained to enter the data. And then when it comes to the analysis, they used IBM Statistics Software version 21. And the author also stated that they used univariate or multivariate analysis. And finally, they did tests of statistics significance. You can see that we have seen a lot of p-values in the paper. So either they used ANOVA, whatever it is they used to apply, to get the statistical significance. So they also obtained permission, let me put it like that. So we have the ethics section here, and you can see that the first part is that they obtained permission from the KNHU and ERC. There's a number, and they also have the Jaramogi Oginga Odinga Teaching and Referral Hospital Ethics Board. Here is the number. So what were the results? So they found that the author had already divided the factors into socioeconomic, cervical cancer screening and reproductive factors, and HIV characteristics. And they went ahead and they tabulated this data. So it's a lot of data and it takes a lot of time to analyze, but we can go through one table together. And then the rest of them, I think we can set them aside for the critical appraisal section, so that we better understand how the author came to their conclusions. So we have the first table, which in this case was summarizing the social demographic factors. So we can start together. So the mean age for both the cases and the controls, you can see we have 47 and 46 here. And you can see they were also comparing the levels of education. So you can see in this case, those who had secondary education here were 57. And in this case, those that had less than secondary education were 43. So the inverse now, on the flip side, those had more than secondary education were at 41 here, and here they were at 57. So maybe the author would have been likely to conclude that people who had a higher level of education were less likely to have invasive cervical cancer when they're infected with HIV. And then we went to the marital status. Our women are not polygamous, they are polyandrous, but all the same. Single, you can see the numbers, we can see monogamous, we can see that those who are separated or divorced. So most of them are monogamous anyway. So I don't know if that's statistically significant. So for the employment status, we can see that most of them are self-employed for both groups actually. And we have salaried women in the cases section, and we have controls women. They are salaried on the control section rather, sorry. So we're going to see later how that is significant, because you can see the numbers are almost the same anyway. We have the types of homestead. Remember, these are variables, there are several. We have the semi-permanent households. You can see more women in the cases section live in semi-permanent households, homesteads rather, than the control section. And then we can see the distance to the facility. Somebody lives a whopping more than 4 kilometers from the facility. So obviously, acquiring healthcare services is going to be very difficult. You can see in the cases section, we have a problem, yeah? And then we have means of transport. They're almost similar, but not very similar. But we can see that in the cases section, more women use matatus. Wengine ni wanduthi. Yeah, motorbike section, in the control sections, they're more likely to use. They're still more likely to use matatu, but at least a bit more are using motorbikes. Yeah, so that was the first table. The other tables are similar. We'll do more of that in the critical appraisal section. I know that people who are rubbing their hands ready to criticize seriously. Yeah, we had the cervical cancer screening and reproductive factors, and we also had the table on the HIV characteristics. And when we go to the discussion section, these are the conclusion. This is what the authors rather came down to. So women who had low education levels, we saw that. Women who have no salaried income, we saw that as well. Women who use public means of transport, live far from the hospital, live in semi-permanent homesteads, have a lower CD4 count, and have a shorter duration of infection, are likely to be housewives, have increased screening, and have a higher parity, that is more than 4 children or more than 4 pregnancies, are more likely to be infected with invasive cervical cancer than those without. So, similar studies have been done in several places. So, locally, we have Dagoretti. They did a study also in Uganda, in Nigeria, and they found that these people had similar trends in social demographic factors, reproductive sexual behavior, and HIV-related factors. So these are things that stem from ignorance, poverty. These are the kind of things that affect women who are infected with HIV and AIDS. So they're more likely to get invasive cervical cancer. We had a study done in Cote d'Ivoire, which showed an increase in pap smear screening in HIV-negative women compared to HIV-positive women. I don't know how they did that, but that's how it should be. The difference was seen in the methodology of the study. So yeah, that was the difference. And then we have a study done in Nigeria that showed both HIV-positive and negative women with higher CD4 counts had a lower incidence of cervical precancerous lesions. But the difference here was that in the study, the controls were HIV-negative women with cervical cancer. Yeah. What are the limitations of the study? So you can see limitations include missing data in some records. So when you take your histories, make sure you write your histories very well. Retrieval of older files. My goodness, you know what files look like in these public hospitals. They are feet tall, 2 feet tall, 10 feet tall, the whole building tall. Possible misclassification of some patients with stage 1A invasive cervical cancer, which is possible, of course, Yeah, so we need you guys to be gynecologists. I hope after this appraisal, we're getting a few gynecologists from here. So what are the strengths of the study? So this is a pioneer study for the HIV-infected women done in this setting. You can imagine in a country with a 19.9 prevalence, this is a first study, guys. This is where we need researchers. So, in conclusion, what did the author recommend? I hope you can remember what we started with. So, provision of counseling to increase awareness, information, and health-seeking behavior. So, we agreed that some of these people, the less education you have, the less likely you are to get tested and screened for cervical cancer. Schedule of frequent screening amongst HIV patients and follow through in their care plan in suspicion of cervical cancer needs to be undertaken. This is a very, very serious disease. I mean, cancer is such a scary disease, and we just need to follow through and make sure that our patients are okay at the end of the day. And finally, pap smear tests should be used more as a screening tool and not only as a diagnostic tool. That said, we move on to the last slide, which includes the acknowledgements. So our author acknowledged I guess this is the organization that funded, or no, the study was actually self-funded, so probably that supported the study. We have the supervisors, we have the hospital itself, of course, where the author was getting the patient record, and finally we have the family. And finally, for the references, I will leave that for the appraisal part. There's a lot to critique and there's a lot to appreciate about this paper. So we want to thank the authors and we want to thank JOGECA for giving us this paper to go through, to present, to criticize. Yes. My presentation is over. Thank you. Any questions are welcome.
Thank you so much, Wandari. That was a wonderful presentation. I think we've all really enjoyed it and stayed engaged from start to finish. Thank you for appreciating her as well. So at this point, we'll move on to the most active part of our sessions. As is tradition now, we'll delve into what we read throughout the past 2 weeks, and we'll share our thoughts and our critiques of this paper. So I will go through it, and Najma will also be helping to also moderate this part of the session. And we'll encourage you to be as active as possible, be as engaged as possible, unmute. But wherever not everyone is able to unmute, so you can use the chat box. But if you'd like to speak, I kindly raise your hand so that Najma unmutes you, and then you can proceed to speak. So we'll start with the first part of the paper. I hope Najma, you're back on. So oh yeah, okay, great. So we'll start. So we'll share our thoughts on this case control study, and we'll start with the title and authorship. So as you reviewed it, did you find that the title was clear? Did it specify the disease, the exposure, the design, and was it also reflective of actually what the study was all about? And are the authors and affiliations appropriately represented? So you're welcome to unmute and give your thoughts, and also use the chat box as well. Najma will be reading out as we proceed. So there's a raised hand from Kevin. Maybe Najma, you can unmute him.
I'm trying to locate Kevin.
Kevin, just raise your hand once again, or whoever wants to speak. I think he put his hand down. Okay, yeah, let me just allow him to talk. Okay, Kevin, go ahead.
Hi everyone, am I audible?
Yes, you are. Go ahead.
So, from my perspective here, I think the title clearly defines first, we have the exposure, which is HIV and AIDS, and then the outcome, which is invasive cervical cancer as well. It also clearly defines the study type. The author states that they used uh, case control study for the 5 years, sorry. And then the author and their affiliations are also well stated at the uh, are also well stated, and the keywords they are also well mentioned. So I think the author did a good job here in stating all that. Yeah, thank you.
Thank you, Kevin. You can also have someone else who would like to share additional thoughts, and then Najma will read the chat box. Okay, I guess we can go to the chat box. Najma, you can read them out.
Okay. So the first one is from Samson. Sorry, Sumaya. The title identifies the outcome, the population, the setting, and the study type. Authorship and affiliations are clearly represented. The main exposure is not clearly stated in the title. Then we have Samson. The title is informative. The title is informative and clearly states the outcome, that is invasive cervical cancer, the key population, women living with HIV and AIDS, the study design, hospital-based case control, the duration, 5 years, and the setting. It meets the expectations. Authorship and affiliation are appropriate, and correspondence email is provided. Then we have Cynthia. The title clearly states the exposure, the outcome, the population, the study design, and the time frame, which is very commendable. Then we have Lomi Acheng. The title clearly identifies the disease, that is invasive cervical cancer, the population, women living with HIV and AIDS, the setting, Jaramogi Oginga Odinga Teaching and Referral Hospital, Kisumu County.
Okay, I think maybe we can just, because I feel like they're pretty much the same. Maybe let me see if there's any different. I think there's a question from Margaret. Is the exposure risk factor for HIV/AIDS? So in this case, because it's a case control study, so the participants have been classified based on their outcome status, and so you have cases which are these people who have HIV/AIDS with invasive cervical cancer. Those are the cases, and the controls are people with HIV/AIDS without invasive cervical cancer. So those are the cases and controls. And then the exposure now is the risk factors that were being assessed. So the assessment was for the exposures. So I think that answers that. I think the rest are all the same. Just I think we can all agree. I think the title was okay and well written and comprehensive enough and quite informative. So we can move on to the abstract. So does the abstract summarize all the key elements of this study? And does it have the main summaries in terms of also the statistics in terms of what you'd expect from a case control study, like odds ratios and corresponding confidence intervals, and just the summary and implications of this study? So feel free to unmute and share your appraisals.
Yeah, I can go for this.
Yes, Clarence.
Yeah, so the abstract is it's good. It's well able to summarize those key elements. The background is able to give a brief overview of the disease and the burden that it has. The objective highlights the research question. Then for the methods, the study design, the study setting, the population were highlighted, and also the analysis approach was mentioned, but the definitions of the cases and the controls were not like explicitly mentioned. I guess it's implied throughout the abstract, but it wasn't specifically mentioned. I guess I said the study design was an unmatched case control study, so I guess the matching criteria weren't required, although I'm not too sure about that. For the results, most of the major exposures, they had odds ratios, they had the confidence intervals and p-values, but low education level and higher parity didn't have those. It only had p-values. Then for the conclusion, it was good. It gave a good summary of the findings. And for the keywords, I know it wasn't in the abstract. It was right before it. But it did have two keywords, but it was only human immunodeficiency virus. That's a mesh term. The other one, invasive cervical cancer, is not. It's only cervical cancer that's a mesh term. But I guess the author chose what they chose. Yeah, but generally it was good.
Thank you, Clarence. And maybe you could expound a bit more for people who are listening and wondering what a mesh term is. You can also expound so that others learn.
Yeah, sure. It's MESH stands for medical subject headings. They are basically these terms that you put into PubMed, and I guess they direct you to all the papers and all the research that revolve around that word. So if it's human immunodeficiency virus, you'll get all the papers that are there. Something like that, yeah.
Yeah, thank you. Yeah, there is standardized words that are useful when searching in various databases. So thank you, Clarence. I think Teddy, you'd also raised your hand. You can contribute, and then Najma will read the chat box additions. Yes, Teddy, you can. Let me just see. Can yes, Teddy, able to talk now?
Yes, mine will be more of the same. It was really well done, and because they also give in the background the rationale being low data, and the target is probably prevention of working towards prevention of invasive cervical cancer. And they also did well giving the burden as it being the leading cause of mortality in women with HIV and AIDS of women of reproductive age. Also in the methodology, they actually did quite well because they mentioned the case control. They also mentioned the data collection method as being questionnaires, as earlier mentioned. And I think the analysis has already been covered. Mine is just a minor add-on.
Thanks, Teddy. Najma, you could check the chat box.
So we have Sumaya. The abstract includes the background, the objective, the methods, the sample size, and the main results. It reports significance levels, that is the p-values. The odd ratios with confidence intervals are missing. Method section does not clarify how exposures were measured. The keywords are minimal and not standardized using MESH or the WHO terms.
Okay, thanks. I think so. The additions and improvements we'd make to this abstract, I think in summary, the case definition and control definition is really, really important. I think that's the main thing anyone would want to know from the study. So it should be well stated in the abstract as well. And also, but we'll come to the results and methodology later. The abstract is just a summary of what was done. So I think we'll move on to the introduction. So again, for the introduction, was it a good, concise literature review? Did it highlight the gaps and clearly bring out the research question and the justification for this study, especially now being a case control? Why, and also just hinting at the relevance of this study. So were all these things well brought out in the introduction? So once again, anyone who'd like to unmute, you're welcome to raise your hand and you'll be unmuted. Yes, Teddy, you can go ahead.
Okay, so for the intro, they really did it well because they mentioned the regional burden being 87% of global deaths, of which global deaths are 311,000. They also mentioned why they chose Kisumu in mentioning that its prevalence nationwide is like 19.9% of the nation burden, and the rationale, they also covered it quite well because they mentioned they just wanted to fill the knowledge or data deficit gap, and they also wanted to determine the risk factors for disease. So I thought it was a good intro.
Okay, thanks, Teddy. Any additions? And Najma could be checking the chat box.
Okay, so the chat, okay, I think Sylvie is raising her hand.
Okay, let me see. Allowed to talk. Sylvia, you can proceed.
My name is Sylvia Mora. I'm from the University of Nairobi. So to reinforce on what Teddy has said, on the introduction, the rationale was clear and relevant to regional clinical practice in that the author clearly showed the global burden of cervical cancer, the local relevance to Kenya and Kisumu County with high HIV prevalence and even the knowledge gap. So that makes the rationale clear and even relevant to regional clinical practice. So the objective is also explicit. it has been mentioned that clearly that it is to determine the risk factors of invasive cervical cancer in HIV-infected women in Kisumu County. But however, the hypotheses are not stated. Yeah, the hypotheses are missing. That's it.
Okay, thank you. Najma, you can read the chat box now.
Okay. So we have Samson. It has an excellent regional context. It related the cervical cancer as a leading cause of cancer death in Kenya, and the extremely high HIV prevalence in Kisumu. It clearly identifies the knowledge gap and justifies the case control design. Clinical and public health relevance for Western Kenya is obvious, and it fully meets the criteria. Then you have Margaret. In the background, the burden is described, but statement of approximate figures will be better.
Okay. Thank you all. Yes, I think just a few adjustments to the introduction, maybe, but I think overall it's a good introduction that gives a good background for what the study was and the gap. And for the hypothesis, I think we'd mentioned it before. Maybe it's not always stated, but it's implied by once you mention the objective, you can somewhat imply because now for the manuscripts they tend to be a bit more concise than the whole, let's say, dissertation. That's the initial proposal of a study. So I think that's still okay. And now we'll move on to the methodology, which is the most important thing of any study. So we'll try and dissect it as much as we can. And so looking at the various subheadings that we've repeated over the past sessions in a methodology. So we'll discuss the study design. So was the study design clearly stated? Did they specify the setting, the time frame, the data sources, things to do with ethics? And in terms of selection of cases, did they define the eligibility criteria for the cases? Did they ensure that that the cases are, they're actual cases as well, and that they're not they're not too prevalent for there to be bias? And and did they state the entire criteria clearly? And when they were selecting controls, were the source of the controls mentioned? And did they also represent the population in terms of the number and the statistics behind being able to come up with the numbers of cases and controls? Are they representative? And were they actual controls in that? Were they free of the disease of interest in that? Because controls are the ones, they should be so they are similar to the cases, but they define the most important thing, which is the thing you're studying, and that's how you define them. So was that done? And it was mentioned this was unmatched case control study. So we'll not really critique that, but maybe we'll discuss slightly about what matching is and measurement of exposure. So have they mentioned how they measured, and have they also discussed bias and bias control for this study? And for the statistical analysis, was it well done? And ethics we've also mentioned earlier. So the floor is open. So share your thoughts on what you think about what the others presented and any critiques you have.
So the methodology section, I'm just going to give a summary of what from my appraisal. So in terms of the study design and the setting, the study design is written as unmatched 5-year case control. However, The author at the beginning did not indicate if it was retrospective or prospective, though later on we come to find out that actually it was retrospective. So I think that should come out clearly at the beginning of the first sentence if it was either retrospective or prospective. The setting was clear, Jaramogi Oginga Odinga Teaching and Referral Hospital. The time frame was also indicated as 2012 to 2016. But I wish the author would have indicated like the months. Was it January of 2012 to December of 2016? So the months should have been included. Data sources was clear. It was health records of 100 cases of HIV-infected women with histological diagnosis of invasive cervical cancer versus the HIV positive without. Ethical approval, it was present from both KNH, ON, and Jaramogi Oginga Hospital. And selection of cases, it was clear how the cases were selected and the controls, how they were selected. And it was those who are attending the CCC and the gynecological clinics. And how the histopathology was done, it was clear that it was done in an ISO-certified facility. So we believe that the quality of the results were good of the diagnosis of the invasive cervical cancer. And also there were other screenings that were indicated. And also there was the staging. It was provided the staging of the invasive cervical cancer. For the controls, also it was clear. Though now the section for matching and comparability, the author reported that it was unmatched. So, and I was saying in the critical appraisal, though we've said that one will not critique because it was not matched. So the measurement of exposure, so this subsection, the exposure was the HIV infection, and in the exclusion criteria, they say that those patients who lacked serology results from the laboratory, they were excluded. So at least it was for all the patients, it was confirmed that they were exposed to HIV. In terms of the tools, the questionnaires that they were used, yes, it was indicated that it was structured, but however, the process of validating and making sure that it is reliable was not mentioned. There was no pilot testing that was done. And the data collectors, it was not indicated if blinding was done. For confounding and bias control, they mentioned the exposure variables and the social demographic factors and the behaviors, the sexual behavior and HIV-related factors, and the outcome as the invasive cervical cancer. The author reported that in the abstract that multivariate analysis was conducted that will be for controlling bias. A statistical analysis, this section was quite brief. It was just mentioned that yes, the IBM statistics software version 21 was used. Those univariate and multivariate analysis. However, in the tables that were presented, there were no crude or adjusted odds ratio with the 95% confidence intervals. Only the p-values were mentioned. So I thought that was important to include everything, the tables, and I didn't see if it came in the supplementary materials. Then lastly, in terms of ethical considerations, this just going beyond the ethical approval from KNH and Jaramogi. Informed consent was not mentioned, but for this case, my assumption was a waiver was done because it was just chart abstraction. So that should have also been written, that maybe a waiver of consent was done because it was chart review. And it was indicated that a password-protected Microsoft Access database was used. Yeah, so generally well done, just the few areas that was supposed to be added. Thank you.
Well, thank you so much, Susan. That was very detailed and comprehensive. Maybe you could tell us your institutional affiliation, as the rest also appreciate you for that good report.
I'm Dr. Susan Kuria. I'm a psychiatrist interested in research, general research.
Thank you so much.
Yeah.
Thanks. Anyone who'd like to build? Wangare, you can proceed.
I finally figured out how to participate. Sorry. So, Dr. Susan has nicely analyzed this methodology, but I thought it would have been important to indicate if these cancer cases were newly diagnosed or not. The author did not indicate that. Also, she's reminded me of something in the abstract. The odds ratios are not given for all the factors, just for like the last three. The first three do not have odds ratios. So I think that's all I wanted to add. Yeah.
Thank you. Thank you so much, Wangari. I think it's also something that I was also asking myself, because again, we always ask ourselves what could be a source of bias in this study, whichever study we are looking at, because you look at, yes, one study, in terms of cases and controls, these cases are people with invasive cervical cancer. These are the ones non-invasive cervical cancer, but you know, uh, how long have these people had cancer for? At what stage was it diagnosed? And yeah, is it an actual fair comparison that makes sense? And so yeah, I think that's a very good point. And for the odds ratio, that's the main statistical method of reporting case controls, and so it ought to be brought out and much better. And we'll see that in the results. It wasn't very consistent, and we've seen even in the previous discussions that the statistics often let very good studies down. You can do a very good study, but then you end up messing a bit with the statistics, and then it affects the quality of the results, which is the main thing you get from the study, and that's a big area of concern. So I think we'll additionally share some additional materials for further reading after the end of this session on odds ratios and case controls, and matching versus where matching is applicable, and how to also and unmatched case control studies as well, just to also continue learning more on this type of studies. So Najma, you can read out any additions or concerns that have come out in the chat box.
So we have Margaret. In the abstract, the burden is described in the background. No, that was from before. So we have Anthony. I like to try. There's a bit of bias from confounders. The control or not matched with the cases based on potential confounding factors such as stage and duration of HIV infection. I think that's all.
Okay. Was that line? Was that sentence from the study itself? Maybe I may have skipped it. Where they justify why they used an unmatched study. Maybe I didn't see it, but it's important to justify why they used an unmatched study. But it's probably because they couldn't match the duration of, having cancer, and there are other variables that affect that introduce bias. But it's important to state it explicitly so that yeah. But I think that's okay. So any other additions? So that we move on to the results. Okay, I think we can move on to the results. Thank you so much for your contributions. So in terms of the results, we again welcome you to share your thoughts. So did they have a flowchart, a nice participant flowchart? Did they present the baseline characteristics and demographics well? Did they report the odds ratios with 95% confidence intervals and significance values? Did they show the results from both the univariate and multivariate analysis that they did? And were the results relevant? Yes, and all that, as well as any tables and figures. Okay, there weren't any figures, but any supplementary materials. Just you can give their critique at this point. So again, you're welcome to share your thoughts. The floor is open.
Okay, mine. I really didn't want to critique that part. But I can say just generally it was well done. But my question, I actually had a question rather. It was about the table. The tables. I'm seeing it had like some figures which were written and then others were in brackets. So could someone just like slightly explain why there were some figures that were in brackets and figures that were not in brackets? And if you add the figures that were not in brackets, most of them were not coming up to the number of cases or the number of control. That was my concern. Maybe if someone could explain.
Anyone would like to give it a shot?
Yeah. Guess the numbers in brackets were the percentages. That was my guess, and then the numbers not in brackets were the actual numbers. So for the first table, you can see 50. Okay, maybe to the controls, 43 patients versus 43%. If that makes any sense. They didn't add up to 100 for a lot of them, but ideally, because there were 100 patients for each, then if it's
It's a conventional way of representing the data in tables so that you're able to present it in a concise way. So that's why at the top they'll put n and then the brackets, so percentage n. So you'll find that n is the number, the absolute number, and then the percentage is the one in brackets. So and then throughout that will be the case in terms of the representation. So and for the percentages, it'll just be adding up to 100. But yeah, so that's it.
Okay, so considering if it's like that, then, for example, on the marital status, for example, we have the controls here on the monogamous. We have like, for example, 66 are monogamous, but then the percentages are coming up to 70%.
So I think because so it's because it's they had this single, monogamous, polygamous, and divorced / separated. So I don't know. We had all this. Does it come to 100? 66 plus 7. That's 73 plus. Okay, and maybe there are some they couldn't account for. But Purity has raised her hand. You can let me just unmute you, or Najmi, you can help me unmute them.
So on the marital status, I noticed there was a minor disparity in some of the figures. Hello, can you hear me?
Yes, we can hear you, Teddy.
Okay. So on the marital status, I noticed the figures were not adding up because on the controls the percentages was above 100, and then when you follow it up with the table that has discordant couples, which is in table 3, so you'll find they have cases being at 89, and if you go back to the table for married people, the monogamous is at 62. If you add it up, it comes to 86. So the figures for the table 3 discordant couple and the one on marital status was also slightly not adding up, on top of the percentages not adding up.
Yeah, I think that's true. I think maybe they had missing data. I think even part of their limitations, they mentioned they had some missing data where I think Wangari had said maybe history is not complete. Yeah, so they had some missing records. I think that will be the main contributor. So, and they decided not to disqualify entirely based on just a missing marital status. But yeah, they ought to maybe have explicitly explained why they did not add up. And yeah, good job for also analyzing the table again, since a lot of information is hidden and or can be misrepresented in tables. That's why they need to be looked at with a keen eye. So any additions, any further discussions within go ahead.
I think I've been unmuted. So can you guys hear me though?
Yes, Purity, we can hear you. Go ahead.
Okay. So I think let me just give a summary of what I had for the term. So for me, I felt like the participant flowchart was placed in the methodology section rather than the results section, but baseline characteristics comparing the cases and the control groups were provided. Exposure frequencies have been provided with p-values, but no odds ratios and confidence intervals are stated. It is noted that the tables show varying numbers of the total participants, that is both cases and controls, varying from as low as 8 participants in the cell showing cases with STIs in table 2 to as high as all the participants in some of the other rows. This indicates a likelihood of missing values, which is not accounted for. And most of the percentages given are correctly calculated based on those values that they had, except for like table 2, where in the STA section, where there is like a gross miscalculation of the control group percentages. Yeah, I think that is what I had for on my side.
Thanks a lot, Purity. You can also mention, yes, I remember to mention which institution you're from.
I am Purity Lavin Wakasa from Kisii University.
Okay, thank you so much, Purity, for that addition. I think we can have Purity's remarks as maybe the last ones for the results, and then we can move on to the discussion so that we end in time. So for the discussion, according for your appraisal, did they interpret their results appropriately? So did they give like a brief summary of their major findings? Did they interpret their results well in an evidence-based manner, in a giving balance, not too biased or exaggerating the results and their applicability? And have they acknowledged clearly any biases from how they conducted the study and limitations? And have they given the implications of this study meaningfully and in a realistic way? So the floor is open. You can share your thoughts on the discussion.
Before that, there's a question
Oh, sure.
on here. So the question is it necessary to have an equal number of controls as the numbers appearing in the cases? That's from Lona.
I think I will give it a shot. But maybe if anyone else has more experience and other thoughts, you're free to share. So not necessarily, but it's recommended that the number, you don't have a class imbalance. A class imbalance is where by the two groups you're comparing are not even remotely close in terms of numbers. Imagine comparing a group of 300 to a group of 5. So statistically, even the statistical tests that are applied are not able to, you can't compare them. And so it's better. So actually, we can have an exact match of numbers, the better. And but once you have like really huge numbers, it's not that big of a factor. But the numbers shouldn't differ too much. That's from what I've seen. Yeah, class imbalances are a source of bias. So yeah. So, but if anyone else has additional thoughts, you can share. Maybe it's one of the things additional reading materials will share on class imbalances in and also because sometimes you'll find yourself because in the real world you'll find the only cases you will find because sometimes these studies are used for rare cases. You've only found something that has only 5 people, but maybe or something. There are in situations where that's the data that you have, but you need to work with it the way it is. So there are techniques that you can employ to try and delimit that limitation. So yeah, that's something else we'll share as part of reading materials after this session. And then, okay, we can share our feedback on the discussion.
I think I'd like to share a bit about the discussion.
Yes, girl, please go ahead.
In my opinion, the discussion was really well done. They were able to interpret the results very well. They were evidence-based. We were seeing they were linking them to the results they had gotten, and even giving comparing them to other studies that had been done previously, like the one that had been done in Dagoretti, in Uganda, Nigeria, Cote d'Ivoire, and yeah, and then they were also able to give the limitations clearly, and they acknowledged the limitations that they had, and also I think they also gave us strength. If I'm not wrong, they also they gave us strength that it was a pioneer study, and also I'm not sure I picked up any biases that they clearly acknowledged, but at least I was able to pick up the limitations. And the implications of the studies were meaningful and are realistic because, as it was mentioned prior, that invasive cancer is a huge problem in upcoming or middle and low income countries. So I think it's a meaningful and realistic study. I'd also like to point out something that I saw in the discussion, just at the beginning, where they were saying that the findings of the study revealed like the risk factors, and they were saying that lower education levels those who live in semi-permanent homesteads, and then they also said that they were housewives. Now, according to the table that we had on the social demographic factors, housewives, the number of cases were only 10 compared to the ones who are self-employed and salaried, who were 75 and 14. I thought that was a bit not very clearly well, like it's not really accurate, because if it was so, then the number of housewives in the cases would have been more, but it's not clear like from the table. Yeah, that's what I had.
Oh, thank you, Lueli. I think that's a very good catch because it's from the data, it's actually false what they were saying here. So yeah, thank you. That's a good catch. Wangari, you can go ahead.
I also noticed that for this study, there are situations where the author would write that women in Kisumu County are the ones affected by this problem. And in some sections should state that women in Jaramogi Oginga Odinga would be affected by this problem. So I felt like she was generalizing. I feel like it's a mistake, yes, but she was generalizing for certain situations when she should have been specific because she studied a small population, not the entire county.
Okay, yeah, thanks for that, Wangari. Yeah, okay.
So on the chat,
Yes, from the chat.
we have Susan. The discussion section did not include the global literature for comparison, and then purity. I think the 10 might be low, but compared to the control value, which is 0, then it can be assumed.
Okay. Okay. Yeah, thanks, guys. I think that's a good enough sufficient discussion on the discussion. So I think overall it was a good discussion and well done since I think yeah there's no perfect study. Maybe they all have a few things here and there, but I think it was good. So we'll come to the conclusion. So in terms of the conclusion, was it concise? Was it an actual real takeaway from what the study did and found? And have they given actionable recommendations for clinical, public health, and research uses? So conclusion, and talk about conclusion, acknowledgement, funding, conflict of interest, and all the declarations as well as the references with this part, so that we go to the last part of our session, and we can keep it concise. I guess we can have maximum 2 people or even 1 person, and then we can wrap it up. So anyone who'd like to close this session for us? Najma, any feedback in the comments?
For now, no, there's no feedback. But there was a question that was asked previously, and it has been answered by Lumi Echeng.
Okay, yeah, thanks.
Yeah, maybe I can just give some conclusion since I have the mute and unmute button with me. So the conclusion is precise and supported by the data. Actually, it's well written. The only part that is missing, and there's the implication on policy. However, the author did not direct future research. In terms of references, we noted that there are only 9 references. Minimum recommended is 20. And then for the dates of the articles, considering that I think the student, this was done around 2017. So for that time, I think for these references, they are relevant. They are within 10 years, considering the time. The majority of the references were actually from Africa. The authors should have also balanced with global literature, and the format was, the style is good, Vancouver, and it was consistent. Yeah, and in terms of just the quality, I think it's relevant. The article is very relevant and within the scope of the JOGECA. Yeah, thank you.
Thank you so much, Susan, for concluding our session very, very well. So I think it's been another fruitful discussion. I've personally enjoyed it. I hope you have as well. And again, we continue to learn from each other, which is, I think, one of the best ways to learn, peer-to-peer learning. So at this point, I will hand the session back over to Najma, who will introduce our guest editor for today. So Najma, over to you. Thank you all for the lively and productive and fruitful discussions.
So as we are coming to the end of today's critical appraisal bootcamp, I am pleased to invite our guest today, Dr. Koigi.
Hi, everyone. Can you hear me?
Yes, you're audible.
All right. Thank you for the invitation to this session. First and foremost, I would like to tell Wangari, thank you and congratulations for a job well done. You did a commendable job in bringing out the important features in your presentation concerning this paper, and you are able to simplify things that to the audience now within a concise and well done presentation. So keep it up. And to everyone else, you did such a fantastic job in analyzing and critiquing this paper. So what I can say is that you mentioned most of what I had actually written down in my notes. And I would just like to say that it's important. What you're doing is important. I think this bootcamp is, number one, supporting the agenda of supporting research amongst us, amongst Africans, because one of the main issues that we have is that we do not have enough studies. We like quoting other people's studies, but this brings out the need to actually do our own studies. Number two, the ability to critique evidence that has been said or that has been written gives us a platform to actually have better studies, better evidence, because you're able to know what to do, what to critique, what to analyze, and the important things that you need to bring out. Of course, it's commendable what the authors have done in this study is commendable, being the first study in that region. And of course, it's no study is perfect, but we can always improve. There's always room for improvement. And so we've identified the strengths of this study. We've identified the weaknesses. But it being a study, it being a manuscript, it's important to be concise and be clear and be thorough in whatever it is that we are trying to bring out. Of course, some of the main things that we need to consider when we're doing research is what exactly we want to study. What is our research question? Because everything else is derived from the research question. Once you are able to clearly identify what exactly you want to study, then you get the title of the study, you get the objective of the study, and you're able to know what type of study you are going to do, whether it is an observational study. In this case, it's a case control study, whether you're going to do a systematic review, whether you're going to do an experimental, whichever it is that you're going to do, it clearly comes out from the research question. Now, what else I can say about these studies? It's good that you're able to pick out the weaknesses in this study. And of course, it being a retrospective study, there's going to be a lot of gaps, especially in public hospitals, as Wangari rightfully said. So it's a question of working with whatever it is that we have as far as the data captured is concerned. And I think the authors were able to bring out the risk factors, as they said, and it came out quite clearly despite the weaknesses that were seen in the results section. Otherwise, I'll say keep it up. You're doing a fantastic job, and we hope that in the next few years we'll have more quality evidence and we're able to show the intellectual talent that we have within Africa as well. Thank you.
Thank you so much, Dr. Koigi. I think let's appreciate her for taking her time to also join us. And we thank the entire editorial team at JOGECA in extension for also agreeing to collaborate with us at EAJNS for this initiative and also for sharing your work for these sessions. So thank you all for participating and joining. We'll again reconvene after 2 weeks, but I think we've noticed maybe that attendance has dropped slightly. I know things are getting thick, but again, we'll strongly encourage you to be attending these stand-ups that we've been organizing, not just submitting the reports, and also ensure you submit your reports. We shall have the session on 18th, and then after that we shall break for Christmas, and during that time we'll have an evaluation, maybe like a quarter Q1 evaluation, just because we'll have more time to maybe assess what you've been doing and mark your attendance as well, and just so that you're able to see how you're doing as part of the bootcamp. So far so good, and see you in the next session. So good night and thank you.